Welcome to Johnston County EMS's online continuing education program. Got an exciting topic we want to talk about this month. Sports related injuries, something we really don't cover a lot in our initial program that we take, whether it's our EMT, medical responder, intermediate paramedic. We talk a little bit about traumatic injuries, but we don't go in depth about sports related injuries. Hockey, soccer, football, baseball, kind of the big things around North Carolina. We don't talk much of how to treat and manage these injuries, but what we're going to do today is kind of do a brief overview of some different type of injuries and kind of got some pretty good interesting videos we want to show you. So what's our objectives that we're going to go over? First, we're going to overview different types of injuries sustained during football games. Also, a little bit about baseball and a little bit of kung fu martial arts. Talk about concussions, some causes of sudden cardiac arrest. Talk about commotio cordis for those of you that have never heard of it or seen it. This is going to be your introduction. Talk about a few cardiovascular disorders, and we're also going to review the steps of proper football gear removal, when to remove it, how to remove it, and certain steps you need to take. And we'll also talk about the North Carolina High School Athletic Association policies as well. We got up to 3.8 million athletes a year in the United States suffering from sports related injuries. This is the NCAA stats. As you can see from the different percentages, your lower limb extremity injuries are going to be your highest at 50.4%. One of the biggest things we're going to talk about, of course, is concussion and spinal injuries. As you can see by the NCAA stats, concussions is about 7.4%. High school football. Everybody loves high school football. It's very big in this area, and at some football games, some of the parents get more competitive than the high school athletes do. At Johnston County EMS, we cover several football games. We send dedicated units to those games. We send on duty units to those games. We've got paramedic coverage at the majority of any football game that goes on in Johnston County. And there's a lot of injuries that occur. Hopefully, we won't have to worry about these injuries, but in case we do, we're going to learn about exactly what we're going to do to properly manage these patients. In 2005, there was over 1 million students that played high school football. I remember I was a senior in 2005. We had a very good football team that year, or at least I thought they were. And there was always a ton of students there cheering them on, and they were hitting hard, they were playing hard, they did a great job. Football's the leading cause of injury in high school. There's over 300,000 students that are estimated to sustain an injury while playing. So these kids, they're hitting hard, they're playing hard, they're running hard. They're going to get hurt. It just comes with the sport. So we're going to learn how to properly manage these guys whenever they get hurt. They might sustain some type of injury. We're going to kind of review on how to treat it. At the high school level, you're looking at about 96% of head and face injuries are concussions. These are your patients, that'll come to you. They got hit hard. They're like, man, I feel sick on my stomach. I got a bad headache. I just don't feel good. Something ain't right. Well, chances are they've sustained a concussion. Neck and cervical spine injuries, they're about 4.1%. And out of that 4.1%, almost a quarter of them have some type of nerve damage. Now, this can be temporary or it could be permanent, but just think of a permanent nerve damage at the high school level where these folks could be having some neurological deficits, possibly paralyzation. If these kids are looking at doing this at a professional level, this could be a career ender for them. So you're thinking that you've got an injured player and you're wondering what exactly is the sign and symptoms of a concussion. Well, here they are: confusion, headache, nausea and vomiting, dizziness, sensitivity to light and noise, fatigue, and concentration problems. As you can see, the ones that are highlighted, these are the ones that you're going to see the most: headache, dizziness, concentration problems. I will say nausea and vomiting is probably almost in that top three list as well, because some of the ones that you see out there, They got hit hard. They're dizzy. Well, you know what? Nausea and vomiting comes with dizziness, especially if it's an extreme case of dizziness. These folks that have had concussions, a prior history to them, chances are these folks that get hit hard are going to have another concussion. When you get a patient and they're complaining of those symptoms, one of the key things that you should do is obtain a patient history. And in that patient history, you should be asking, have you ever had a concussion before? If so, how long did it last? What were the signs and symptoms you experienced then? And what was the best way to manage those symptoms that you were experiencing? If they tell you they've had a history of concussion, chances are they probably have another one. And for these folks, each time they have a concussion, their recovery rate gets slower and slower. They're already have a higher suspicion of having a concussion because of a previous injury, so now they've got a longer recovery rate due to that traumatic brain injury that they've already had. Just kind of like think of breaking your arm. If you've broken your arm once before and it being a pretty bad break, you have an accident, you slip and fall, you get in a wreck. You've already got a weakened bone. Chances are you could break that arm again. And if you break it for the second or third time, you continuously have that weakened bone that you have that greater chance of breaking. Kind of the same thing to thinking about a concussion. You've got that continuous chance of having another concussion. During your preseason practice, players have got all their gear on. They're fully padded. Now, at the high school level, they do have to spend, I think it is 3 practices with just like helmet and shoulder pads, running around and practicing drills before they can get fully padded on. Well, these kids, they're ready, they're waiting, they want to get that gear on, and they want to get out there and they want to start hitting. So they've got something to prove at this point in time. So they're going to hit hard and they're going to hit each other with no fear, hitting them as hard as they can, and this is going to increase your risk of having some type of injury due to that hard hit. The preseason, they've got higher rates of concussion opposed to the normal season. These folks are getting out there and they're giving it all they got. You know, this is their time to shine. This is going to be whether they're going to be on the starting lineup or not. So they're knocking their self ridiculous and they're hurting themselves. But it comes with the game of football. Folks hit hard, folks run hard, and it's a full contact sport. Injuries are going to happen. In the NCAA, what is the most common injury? A. Concussions. B. Spinal injury. C. Upper extremity. Or D. Lower extremity. Think about it. Remember the chart we showed. What was the most common injury at 50.4%? You got it? Lower extremity injury. Remember the graph. Concussions are at 7.4%, head and face 4.3, upper limb 16.9, torso and pelvis 11.9. Right there it is. Lower limb extremities 50.4%. This is one of your higher rates of injury. True or false? A player with a history of concussion will be more susceptible to future concussions and will have a slower recovery time. Remember the presentation we showed with the two guys butting heads? That is absolutely true. Any player that's already been exposed to a traumatic brain injury will be more susceptible to having another one. What are the most common symptoms with a patient experiencing a concussion? A. Concentration problems. B. Dizziness. C. Headache. Or D. All of the above. You know what they say? Anytime you get a question that has D, all of the above, chances are that's your answer. So let's continue. Cardiac arrest. This is something that we've talked about in our previous CME sessions. Talking about our survival rate, talking about how we're working cardiac arrest. Well, most of these cardiac arrests we've been talking about have been medical issues. Well, let's talk about a cardiac arrest during a sports game or a sports practice. This can be medical, but it also can be trauma-based as well. There's different type of factors that go into play with sudden cardiac arrest in a student or a college athlete. You're looking at an incidence of sudden cardiac arrest in the high school age students, about 1 in 100,000. Now, 100,000 seems like a lot, but you think about it. Our population in Johnston County is about 170,000. You look at your surrounding counties, population's about similar, if not more. So you're bringing in all these kids for all these games. Chances are one of them might suffer a sudden cardiac arrest. So this is why we really need to be knowledgeable about this issue to try to fix whatever issues we may find out in the field. Hopefully, we'll never have to worry about a sudden cardiac arrest with a student, but if we do, we're going to learn how to fix it. The college level, 1 in 65,000. Why do you think that number's so much lower in the college level than it is at the high school level? My thought process is the college level, you've got more students playing, you've got students training harder. Some of these students are there off of a scholarship, so they have to prove to the folks that funded them and to their peers that they are not only college level worthy, but hopefully they're professional level worthy of an athlete. So these folks are training harder, they're hitting harder, they've got something to prove because this could be their future and this could be how they financially succeed further in life. So my thought process is all of those put together is why there's an increase in sudden cardiac arrest in the college level because they're playing a whole lot harder than the high school level and they're playing various different sports at various different types of skill level. So the question could be, what could be the causes of sudden cardiac arrest in the young athletes? They're pretty well, pretty good in shape. You know, these folks train at almost every single day. They run, they exercise, they lift weights. Not quite sure if they eat right, but these folks should be in the best shape of most anybody. But it can happen. Let's take a look at a graph and talk about the different causes of sudden cardiac arrest in the young adults. As you can see right here, there's different causes of death. You can see you've got suicide, drugs, trauma. Those are kind of ones that, yeah, they're causes of death, but they're not the ones that we're going to focus on. One of the ones we're going to talk about is, of course, confirmed cardiovascular disorders. About 47% is confirmed cardiovascular disorders, and they break it out to the right of different types of cardiovascular disorders that they have figured out that has been the cause. Another one there in the gray is presumed cardiovascular disorder. Basically, they can't figure out what it was, but they're going to go ahead and call it a cardiovascular disorder that caused it. Now, if you look up top, you've got SCT. That is sickle cell trait. This is something that's kind of gaining a little bit of attention because they've been doing some autopsies with these kids that have suffered from sudden cardiac arrest. And through those autopsies, they've seen that these patients are carrying the sickle cell trait. They don't have full-blown sickle cell disorder, but they got the sickle cell trait. There's no underlying pathophysiology of these deaths. It's kind of unclear of what's causing it. A lot of folks that have put research out there have said that if you look at it, the sickle cells they start forming that sickle due to the exertion that they're doing while they're running and playing and hitting and everything else that's involved in sports, and they're increasing that oxygen demand. Well, it's causing those red blood cells to form that sickle shape because of the increased oxygen demand and causing them to form the clusters. Now, this is something that you would see in the sickle cell disease, but for some reason they're kind of relating it to the sickle cell trait as well. So, like I said, really unclear of exactly what's causing it, but I can tell you there's a lot of research that's been out to try to figure out what's going on. There's also been cited in some of the leading causes of death in military basic training. There's been a few instances this year of some folks that's went into sudden cardiac arrest while doing their basic training. There's some of them that's been deemed other issues, but then there's other ones that's still under investigation where they're not quite sure what caused it. There's a strong suspicion that it could possibly be they have the sickle cell trait that could be causing their sudden cardiac arrest. NCAA football players, sickle cell traits associated with exertional death at a rate of 1 in 827 in Division I football athletes. That's been studied, that's been proven. 1 in 827. So the question is, what are they doing? Well, first off, this occurs in a lot of folks, different backgrounds, different ethnic groups, but they're seeing this more in the African American population. In the high school level, they kind of know that it's going on. At the college level, yeah, they're understanding that it's kind of going on as well. There's different screens that they can do before you play football. You can go, and it's about $30 to get screened for sickle cell trait. They can let you know that if you've got it or if you don't. Now, they're not going to throw a red flag up and say, you absolutely cannot play football because you have the sickle cell trait. That's kind of discrimination. What they do say is that if the football player has the sickle cell trait and they're out there playing, they notice that having a little bit of chest pain or some soreness or weakness or dizziness, they're going to say, you know what? We need to slow down. We need to sit down. We need to take a break because apparently what we've got going on here could be leading up to sudden cardiac arrest due to the sickle cell trait. So these patients that are having some signs and symptoms of fatigue, chest pain, cramps, they're letting them sit out for a little bit longer than the other students would, just because they know that they're a carrier of the sickle cell trait, so they want to prevent any sudden cardiac arrest. Commotio cordis, something not a lot of people are familiar with, and then some of them are. It's a sudden cardiac arrest due to a blunt, non-penetrating blow to the chest in the area of the precordium. Basically, a small object hitting somebody in the chest at a certain period of time. This happens when the person's hitting the chest at the 15 to 30 millisecond prior to the peak of the T wave. At this specific time, the patient goes into ventricular fibrillation. And I'll show you an example of that as we go further along. But first, let me show you, for those of you that has never heard of the term precordium, you can see exactly what we're talking about. As you can see in this diagram, it is basically from the apex of the heart all the way up to your aorta. This is your precordium. You can see in this big window that if you get hit in the chest at that certain period of time, this is what's going to cause you to go into sudden cardiac arrest. Now I've got a diagram that shows even more detail than what we're showing right here. As you can see, the kid's playing baseball. The pitch is coming to him, kind of a wild pitch, curveball, gets thrown, hits him in the chest. As you can see at the bottom, there that 15 to 30 millisecond window, they hit at the 20. There's a rapid increase in intracavity pressure, and all of a sudden, the heart becomes unstable. The electrical part of the heart becomes unstable, and it results in the patient going into ventricular fibrillation. Now, of course, the easiest fix for this is early CPR and early defibrillation. And this can be caused by any number of projectiles from a hockey puck, baseball, lacrosse ball, even a fist or elbow to the chest can cause this. Now, to really get an idea of commotio cordis, let's watch a video. And this video is going to show kind of more of how it happens, when it happens, and how quick it can happen. Watch your guy on the left. Let's watch that one more time. Remember, look at the guy on the left, and let's count down on just how quick it happens. I'm going to lower the volume on this so we can talk through it. They're getting ready. Fists up. One 1,000, two 1,000, three 1,000, four 1,000, he's out. Within 4 seconds, he goes out. And that was just that hit to the chest within that 15 to 30 millisecond period that caused him to go into ventricular fibrillation. Now, of course, you would think these guys would kind of recognize what's going on. Apparently, they've never seen this before. I personally have never seen this happen before, but learning about it and knowing about it would make me more susceptible to reaching down and checking for a pulse real quick. Because these guys right here, they're kind of just fumbling around, and somebody there's hollering for a medic. Apparently, hollering for a medic might save somebody's life too. Who knows? So the U.S. Commercial Court keeps a certain amount of statistics about what's going on when this happens, and also what the outcomes are. Now it's only showing the survival rate of 16%, but do you think that every time something like this happens, these folks are keeping up with this data? Like somebody was to go down today because of commotion cordis, the blunt force object hitting them in the chest. If it's not documented properly, they're not going to be able to find out about it. So this number could be a little skewed because of not having the appropriate data. Like we said before, early CPR and defibrillation will fix the ventricular rhythm. All it takes is getting on the chest, doing CPR at a rate of 116 a minute, going the full 2 inches, and having full recoil, and putting those AED pads on or the monitor pads on, and early defibrillation should fix the rhythm. Now, at the rate of 16%, that's not saying it's a guarantee, but it's saying that if you perform this early, you have an increased chance. Other causes that's kind of been highlighted, you got hypertrophic cardiomyopathy. It's basically asymmetrical, hypertrophied, and non-dilated left ventricle. The wall's a little bit more thicker than normal. It's a common genetic cardiac disease. About 1 in 500 has this, and that's a pretty stout number. Most of the time, these kids have no idea that they have it until it's too late and it's found on an autopsy. Also, we've got coronary artery anomalies. I'll show you a diagram of that in a second. Here you've got hypertrophic cardiomyopathy. As you can see, your heart on the left, you've got a normal ventricular wall. Your ventricular septum there is normal with your left ventricle. The one on the right, you've got a thickened left ventricle. So if you look at your heart on the left, you've got a normal left ventricle. You look at the one on the right, you can see a thickened wall. This is caused by the hypertrophic cardiomyopathy. This is hypertrophic cardiomyopathy. Scratch that one too. Look at your heart on the left and then compare it to the one on the right. You can see the left ventricle is very much larger on the right than it is on the left. This has got a thickened wall. The heart can effectively pump, and you've also got a lower amount of blood going through that left ventricle. If these guys are out there running hard, you can obviously tell they're not going to be able to supply that oxygen-rich blood throughout their body effectively because their pump is not able to function. Their heart has a genetic disorder, and it is hypertrophied on the left side where it cannot supply the blood adequately. The anomalous left coronary artery. Look at the one on the left and compare it to the one on the right. Pulmonary artery supplying oxygen-poor blood to the lungs. You've got an anomalous left coronary artery coming off of that pulmonary artery. So you've got oxygen-poor blood going to that side of the heart. Now, it can still function. Your heart can still function, but it can't function well. You don't have 0% blood in that oxygen poor vessel, but you don't have enough oxygenated red blood cells to supply that heart in an extreme physical activity. Doing that extreme physical activity, you're going to be causing tissue death because you're going to increase the oxygen demand on that side of the heart, and you're not going to be getting that oxygen that you need. So it pretty much causes tissue death and, in the end, sudden cardiac arrest. So the question is, what do we need to look for to think of what does sudden cardiac arrest look like with a patient that's playing sports? Well, we got a video here that we'll show you that will highlight exactly what sudden cardiac arrest looks like. So let's mute it and back it up and talk about it. As you can see, this guy's running. He's playing a pretty intense game of soccer. Looks like they've been playing pretty rough the entire game. Take a look at him. He's smiling. Everything seems to be going good. Feeling alright. As he turns around, all of a sudden, something's not right. And just within a matter of seconds, he's out. Sudden cardiac arrest. It can happen that quick. So, a quick quiz. Which of the following is the greatest cause of sudden cardiac death in young athletes? Is it A, suicide, B, cardiovascular disorders, C, trauma, or D, sickle cell trait? Cardiovascular, B. Let's take a look back at the chart to show why it is. Confirmed cardiovascular disease, 47 out of the total 100. And then you've got the 17 that's presumed. So a big chunk of that graph is showing that it is cardiovascular disorders. Per the U.S. Commotion Cordis Registry, what is the percentage of survival of a patient that went into cardiac arrest due to blunt force trauma? Is it A, 16%, B, 1.6%, C, 20%, or D, 61%? And the answer is A, 16%. Let's get into spinal injury. A study was published that defined a catastrophic cervical spine injury. And it's basically a structural distortion of the cervical spinal column associated with actual or potential damage to the spinal cord. Pretty cut and dry. So the National Athletic Trainers Association, they put these studies together and they put these papers together and they send it out and post it for all of these football teams to read. And they pretty much set their guidelines based off of these research papers that have been put together by several doctors. Per the NATA, the spine injury management protocol would be initiated if the following are found, and spine injury management basically means putting them on a backboard. The patient or football player is to be found unconscious, with an altered level of consciousness, kind of lethargic, in and out, not very responsive, bilateral neurological findings, or complaints of neurological issues, not being able to feel one side or the other, and not being able to move, of course. Midline spinal pain with or without palpation. If they say, my back hurts right in the middle on top of my spine, before you even touch it, then, chances are if you're going to touch it, it's going to hurt too. So, spinal deformity will be another one. If there's any step-offs or major spinal deformities, these folks are going to be put on the spine board. And they're probably, of course, going to have some type of neurological dysfunction as well. So the question will be is, well, the NATA says to do this. But what about Johnston County protocols? Well, let's talk about them. This is a clip off of our protocols. Remember the NSAID? Neuro exam, is there any focal deficits? If yes, put them on a backboard. Age greater than 65 years old or less than 5, significant mechanism of injury. If yes, put them on a backboard. Alertness. Here you go with your altered level of consciousness. Are they got any alteration in their mental status? If yes, put them on a backboard. Intoxication. Hopefully, nobody will be playing football at the high school level intoxicated. So, with that being said, if anybody's intoxicated, put them on the backboard. A distracting injury. This is any painful injury that might distract the patient from the pain of a cervical spine injury. Also, this is any injury that if you look at it and you're thinking, man, I bet that hurts, or if it hurts you to look at it, chances are they need to be put on a backboard too, because that injured, let's say their arm's broken 3 different places. They're going to be screaming in pain because their arm hurts. And you're going to look at them and say, they're going to get some pain management medications. Well, you might be distracted from a potential spine injury, and they might be so focused on that arm that they can see, they might not say, hey, well, my back kind of hurts, like right in the middle of it on my spine, and then something really just don't feel right. Because they're going to be looking at their arm and like pointing at 3 different locations and saying, my arm's broke and it hurts very bad. Your last one, spinal exam. Point tenderness over the spinous process or pain to range of motion. If there's any point tenderness to their spine going up and down their back on top of their spine and they say, oh, yeah, that hurts right there, then spinal precaution procedure needs to be put in place. They need to be put on a backboard. Now, here's the kicker. If there is any doubt in your mind that you're not sure if the patient needs to be put on the backboard or not, go ahead and put them on the backboard. Now, of course, our protocol is that, if they don't need to be put on the backboard, use it for extrication, pick them up. If they've got some type of, complaint about a spine injury or their back's kind of hurting and it's really not on top of their spinous process, or you got them on there and it's kind of, there's no real significant spinal injury, then this is where we remove the backboard out from underneath them, because there's more contact on that stretcher than there is with the backboard. But if you back it up and they're complaining of anything like this, significant mechanism of injury, altered mental status, spinal deficits, they really need to be put on the backboard. Other than that, take them off. I'd say use provider judgment. Use your own judgment. So let's talk about football gear removal. The North Carolina High School Athletic Association follows the National Athletic Training Association guidelines like we talked about before. If a patient's going to be put on a backboard, the face mask of that football gear, that football helmet, must be removed. This is so you've got access to the airway. You cannot effectively use a back valve mask on a football player if that face mask is in the way, let alone reach up in there and put a nasal cannula on or a non-rebreather on them, because then you're going to compromise their C-spine by moving and rocking that helmet. Now, there's different types of helmets. Some helmets have the traditional screws on the side. Some of them have quick releases. The ones that have quick releases, they're either going to have one or two things. They're going to have 2 quick releases on the side and the traditional screws up top, or they're going to have all 4 being a quick release. Now, there's different football helmets in different high schools depending on what they've got. Some parents might buy their kids their own football helmet. Not quite sure if that's legal or not, but I've heard of it happening. So keep in mind that there's different type of football helmets. The ones that we've trained on in our last CME session had 4 screws. They were traditional Phillips screws. The ones that I've used at Campbell University have had the 4 screws, but they also had the quick release ones as well. Now, there's different types of tools that are recommended to release that quick release. I grabbed one of those helmets and said, can you undo this with like a pin out of your pocket? They're like, well, yeah, you can. So I pulled the pin out and pushed on the button, and sure enough, it released. So you don't have to have that specific tool to undo that quick release. You can use a pen and kind of, think outside of the box. The football team will have the necessary tools to perform gear removal. So if there's anything specific to that football gear that they need, they'll have. They got a special tool called the FM extractor, and it's made for cutting those plastic pieces that hold the face mask on the helmet off in the event a screw is stripped out. The football team will have all of the necessary tools to perform the gear removal. This is specialty tools to remove the plastic pieces that hold the helmet in place, to cut up the jersey, to cut the shoulder pads if needed. They'll have all the tools at their disposal, and they should. And we'll kind of talk a little bit about some of those tools and go show a video of one of them to show you exactly how it works and to get familiar with it. Now, we're not going to be taking these tools from them and using them. They're going to be using them, but we do need to be familiar with what they're doing and what they're using. The college level follows the same as the North Carolina High School Athletic Association. They remove the face mask only, so they've got the face mask off and they'll put them on the backboard and secure them. Unless there's severe complications. The severe complications would be patient in cardiac arrest, or there is some severe airway issues going on where that gear needs to be taken off. And we'll talk about that a little bit later on. The chin strap, of course, there's a chin strap that holds the football helmet on. If it needs to be unclasped to remove the face mask, just go ahead and cut it. They said just go ahead and cut the chin strap off because sitting there trying to unclasp the face mask will cause too much movement of the head and will potentially cause an issue with C-spine stabilization. But if the chin strap is on there where you don't have to cut it off and you don't have to unclasp it, go ahead and leave it in place. And we'll talk about why a little bit later on. Athletic trainers in Johnston County. There's only two of them that's certified, and they're at Cleveland High School and Clayton High School. They have been trained in sports injuries. They are pretty much sports injury professionals. The downside is there's only two of them. Your football games, some of your football games will have the orthopedic surgeon on standby as well. Dr. Alioto or somebody from his staff will be at one of the Clayton football games. Dr. Alioto and his staff they're pretty well organized when it comes to getting to these football games. They really enjoy the games, and they're there in the event something happens. So, good job for them for being there at the football games. Most of your football games, they're going to have minimal staff to assist. You're looking at some sports med students, the sports med teacher, and also the coaches. So you've got a little bit minimal staff at the high school level versus if you get to the college level and especially the professional level where there is multiple people there that are for the injured players ready to assist as needed and get the gear off and put them on backboards and secure them. It really just depends on where you're at and what's going on. So in the event that something goes wrong, we need to know the proper steps on removing this gear and getting these patients taken care of. So like we said before, there is two different times that we should be taking all of the gear off. And it's during a cardiac arrest where we've got to get to the chest for the pads and a severe airway complication. This will be determined by the highest credential provider on scene. The paramedic on scene sees that there's got to be an airway management issue going on. Let's say you need to bag them, or you need to get in there and drop an I-gel or a king tube, or for some other reason intubate them. If you need to take over that airway, that gear probably needs to come off in order to get to the airway effectively. So the decision is going to be made, hey, we've got an airway issue, let's get this gear off so I can properly manage the airway. Talk it over, get it going, Everybody works together on the scene. Now, we talked about the quick release helmet. I'm going to show a video of the quick release helmet just in case you guys encounter it out there in the field. Now, some of these helmets are going to have your traditional screws where you're just going to use a screwdriver or a drill to remove it. So let's take a look at the Rydell Revolution quick release helmet. That way you kind of get an idea of what it looks like and how to use it. Alright, so let's take a look at the video. As you can see, the quick release tabs there. Pretty much use something small, push in and pull out. This is using a specialty tool. Like I said, a pen can work too. Now let's stop right here. As you saw, the traditional screws were on top and they unscrewed them to be able to get access. Now, I had a question of saying, well, can't you just like fold it up? Wouldn't that work? I've seen that done before on a very older helmet. These newer helmets, the face masks are bigger, there's a lot more curvature on them, and if you were to just pull up and leave it just standing straight up, there's a greater chance that you could hit that face mask and cause unwanted movement of the C-spine. So completely remove that face mask to give you 100% access to the patient. So let's watch a few more videos on proper gear removal. We're going to go into a series of videos here that shows us step by step how to remove the gear. They also show how to do a log roll, how to put the patient onto a backboard using spider straps, and how to effectively manage a down player where you've got a cardiac issue or an airway issue where it needs to be removed. Now keep in mind, we're not going to be leading this up. We're going to be assisting in this because they know all about that football gear. We're showing this and we're learning this in the event that we need to assist. We'll let them know, hey, we've been trained on how to help to do this. What do you want me to do? Not just move over, we've got this, we know how to do it. That's not what we're looking for. We're going to let these folks know we've been trained on how to do this. We've had a little bit of hands-on. Let me help you to make this operate quickly and smoothly, and I can be here for the patient in the event that something serious medical issue needs to be taken care of immediately. So kind of keep that in mind. This is so we can assist in proper gear removal. So let's go ahead and switch over and look at the gear removal steps.
You ready?
Yeah.
Okay. I'm ready when you are.
Alright, we're good.
Okay, so we're going to be holding C-spine. You want to make sure you get your hands kind of locked in down by the traps or as close to the traps as you can get. Obviously keeping in mind pads are going to be removed, so you got to make sure you have enough space there to do that. And then you're going to use your forearms to kind of lock the helmet in place. Just holding it here gives them too much movement when they're going to start moving this around. So we're going to come in here. Alright, now I'm going to stay here and tell people what to do basically. I don't really move from this position until we get to a more realistic position. Now he would have a jersey on at this point, so the first step would be to cut the jersey off. So he's going to do a T shape, so from bottom to the top and down each arm. And then he's also going to cut the straps up the middle, or the stitches up the middle, the laces up the middle. As you can see, when you do that, it starts to open up. And then he's going to cut the straps on the side, or in this case, he could probably just loosen them, but to get those out of the way. Okay, now we get in that position. While he's doing that, now we need someone to come and remove the face mask. So you want to be very gentle with this and make sure you're getting it off as quickly as possible, but also as safely as possible with little movement. So you want to go fairly slow. There's 4 pins or 4 clips, 1 on each of the bottom sides and 2 on the top. And again, nice and slow, but you want to make sure they're removed. Well, this whole time, the person holding C-spine is just holding C-spine. You're making sure that they don't move, trying to keep them calm, conscious if they are or if they're not. And then if you have an extra person, obviously the other person would come over and take over. Yeah. Okay, so now they're going to remove the face mask, get the helmet or the chin strap out of the way. Remove the face mask. Yep.
Now in this situation here, they're not cutting it because this is something that they're using frequently.
Face
So
mask is removed.
in the event that that strap was in the way,
Strap is removed.
you would go ahead and cut it off to get it out of the way.
Now we're going to have another person is going to go and hold an alternate C-spine so we can remove the helmet. So he's going to step over and either squat or kind of kneel, however's easier for him. And he's going to lock his hands in kind of back on the back side of the head, under the ears, and get the jaw in. Forearms are braced on the chest as tight as he feels he needs to. Even if it's a little bit uncomfortable for the patient, you're not trying to hurt them, you just want to make sure they're not going to move. Are you locked?
Locked.
Okay, so now I'm going to relinquish control. And we're going to lift on three, or on lift, excuse me. 1, 2, 3, lift. And when we get them up, then we're going to remove the shoulder pads. They're going to kind of play them down and pull them out of the way. And then I'm going to remove the helmet. You're going to pull up and slide off. And then he's going to slide the C-collar in. And then once we get in that position, we're going to relinquish back. You ready?
Ready.
Down on 3. 1, 2, 3. Okay, I've got control. Go ahead, release. Slide the C-collar in. Here's chin. And then strap it down. And I'm going to lower him down slowly. Now I'm still going to maintain control, and then we'd go to spine board. That's it.
Alright, so that was kind of the steps to remove the gear and put them on a C-collar. Now, she said, reach down in there and grab the traps. Let's talk about that a little bit. C-spine stabilization. Traditionally, C-spine stabilization, we've been grabbing them by the head using our hands. Now, the issue with that is, if you look at where this person has got them grabbed at, there's a pivot point. The pivot point is both of those wrists. So, just think of you trying to manage a patient. You've got room for movement there. Here's another way of looking at it. Grab the patients by the traps, basically their shoulders, and use your forearms to sustain that continuous contact with their head and neck. You've got your forearms locked in place. Your wrist is less likely to move because you've got a bigger contact on their shoulders. And if somebody's face down, like in this picture right here, you can roll them over and cradle their head in your forearms and prevent a lot of unnecessary C-spine movement. So you should really try both ways. Try moving a patient holding the old traditional two-hand technique on the side of the head, and then move somebody with using your forearms only, and you'll be able to gauge and tell the difference for yourself. I always tell people when I'm teaching them how to do proper movement and management of maintaining C-spine, we'll try it the old way, then we'll try it the new way. And a lot of people are saying that grabbing this patient by the traps and moving them, yes, you've got a whole lot more stabilization with your forearms than you do with your hands when you're moving these patients over, and they kind of like it this way. Now, if you're in a car, of course, the patient is pinned into the car. Sometimes you just have to use your hands because that's all you can get there. So This is just another tool in the toolbox to use. You don't have the ability to do this all the time, but in the event you're available to perform this skill right here, grabbing the patient by the traps and using your forearms to stabilize the head, do it. As long as you've practiced on it and you're comfortable doing it, because you've got more stabilization of that head. So let's go over and talk about how to do a log roll with a patient with football gear on. They wanted to show us how to do this so you could properly do a log roll, manage the patient, inspect the back, and just kind of a review of doing a log roll, but with football gear on.
Alright, so I'm going to come in and try to hold a modified C-spine to be able to control the head as much as possible. It's not going to be the same that we would have in a normal situation, but because of the way he's sitting, I can only do so much. So I'm going to come this way. Alright, get in position, everybody. Now make sure there's room to roll him to, we're going to go to my left. Alright, everybody get in position. Are we ready to roll? We're going to roll up to his side. We're going to stop on his side. Is everybody clear? Okay, we're going to stop on his right side, so we're rolling to my left. Is everybody in position?
Yes.
Okay, we're going to do on lift. I'm going to say 1, 2, 3, lift. Are we ready? 1, 2, 3, lift. Okay. Now we're going to roll him onto his back. On lift. 1, 2, 3, lift. Rolling, keep rolling. Alright. That's how we roll.
Alright, so that's how they roll. So let's switch over and let's take a look. We've talked about removing the gear and we've talked about rolling them over if they're face down with the gear on. So now let's take a look at putting them on a backboard, getting them stabilized with the spider straps. So we've been shown how to do a log roll. We've been shown how to remove the gear. Now let's talk about proper backboarding of these patients. And let's kind of review the use of spider straps, something that we don't commonly use a lot and something that's not on the majority of the ambulances out there. But kind of reviewing of how to use them, you'll be able to use them once you get the availability of getting hands on with them. And this way you're not fumbling around with them like you will see myself do in this video. It's been quite some time since I've had to use spider straps.
Record.
Alright, we're still holding C-spine. Everybody's getting in position for spine boarding. We're going to cross the arms kind of over chest or over stomach area, just to get him out of the way. Everybody make sure you got a good hold on him. You're holding on to his body, not necessarily his clothes or anything else. Spine boarding position.
Yes, ma'am.
Okay, is everybody ready?
Ready?
Okay, we are going to lift on lift. So I'm going to say 1, 2, 3, lift. 1, 2, 3, lift. Slide, keep coming, keep coming, keep coming. Keep coming. A little bit further, stop. On down. 1, 2, 3, down. Good, strap them up. Get the seatbelt straps on first. Make sure they're nice and tight. And get the spider straps on. I'm still holding C-spine and not moving. Right now, but normally we'd go really tight. Alright, spider straps coming on in.
Coming up to
He's
you.
got extra point of contact. Those are going to go through these hooks up here. You might have to go to one. Make sure the straps are nice and tight. Should just slide. Your side goes over to him. There we go. Yeah.
Oh, yeah, you flip it over. This one over. 180.
slide it right down by my hand, and I'm gonna slide my hand out. This side. So turn it. And then slide down my hand. Slide down my hand as I move my hand out of the way. Okay, when that strap it back down, you're gonna do the same thing on the other side. Grab him in, and then if you need more, you can take him down through his head, and he's ready to transport. That's it.
And there you go. So let's talk a little bit about the spider straps, since it's been a while since most people have used them. When you're using them, it's beneficial to leave one arm out, as you can see in this picture. The player's right arm is out of the spider straps. Now this is so you can get your IVs, you can do your vital signs and such with this arm. Now they suggested putting the spider straps on these patients because it provides an extra point of contact. Now for the folks that we put the spider straps on, put them on the backboard, use the backboard straps and put the spider straps on as well, they said that there was very minimal movement with those spider straps on. So this is decreasing the amount of movement you have with the patient versus having them on the backboard straps alone. So now that we've talked about how to remove the gear, put them on a backboard, and do everything, let's put it all together and see what it looks like from start to finish.
Okay,
Recording.
alright, go. Gotta get the face mask off, get the jersey cut. DJ, you doing okay? This other chin strap down here by my thumb.
Yep, you can.
Okay. Alright, Casey, assume the position. Brian, grab the seat collar. Let me know when you're in position. Very good.
Good.
Okay, we're gonna lift on lift. 1, 2, 3, lift. Shoulder pads out of the way. Okay, I'm moving the helmet. Lift under his chin. Casey, are you ready to relinquish?
Yep.
Okay, on 3. 1, 2, 3. I got him. Got seat cover in place.
Put a little drag on this side.
Careful. We're gonna lower. Go ahead and get him in place. Okay, get the spine board ready. spider straps ready?
That's fine. Don't do the head ones yet till we put the blocks on. Just hold on for this.
Okay, slide down. Good. Other side. Good. Yeah, we need a little bit more. Get strapped in. Give me a little bit more. Okay. There we go. We should be good now.
Good.
Yep.
One.
Yep.
Is it 1, 2, 3, 4, 1? Just put it right there. 3, 2, 1. Tight.
All right, we in? All right, that's it.
Alright, let's go grab gloves.
So that was basically from start to finish the full gear run removal. Now we talked about some specialized tools that might need to be used in the event that your screws are stripped and you can't get in there with a manual screwdriver and you're having to push too hard to get the screw out and just really fumbling around and causing way too much motion with that C-spine. Remember, you want to have as little bit of motion as you can. You want to prevent too much movement. Now, some movement you just can't help. You've got to kind of adapt and overcome. So, the helmet tools. This is what we is called the FM extractor, FMX3. This tool basically sits on the face mask, and that razor blade that you see cuts through that hard plastic at a ratcheting type motion. And those blades are kind of single use. Once you've used a blade once, you've got to replace it. To get a better understanding of it, there's a video that we're going to show for you to really see how this tool works. Now, the athletic trainers will be using this tool, but this is something that we need to be familiar with and to know what's going on and what they're using whenever they pull this out.
Welcome to Sports Medicine Concepts educational series addressing using the FM extractor to cut various football face mask fasteners. In this segment, we'll be reviewing face mask removal from the Revolution Series football helmet outfitted with the bow tie fasteners, including both the fixed screw bow tie and the quick release bow tie fasteners. The FM extractor handles contain an end effector specifically designed to activate the Riddell quick release hardware. To use the FM extractor quick release end effector, leave the blade safety protector in place while using the pistol grip hand position. Insert the quick release nub of the FM extractor into the quick release fastener button and depress the button fully. With an up and out motion, use the FM extractor quick release nub to help draw the quick release hardware out of the bow tie fastener, while simultaneously pulling the entire fastener away from the helmet. In the event that attempts to remove the bow tie fastener using the quick release system or a power screwdriver are unsuccessful, reposition the FM extractor to cut the fastener from the helmet. Begin by removing the protective safety blade cover from the FM extractor. With the FM extractor completely closed, choose either the 2 or 4 step ratchet setting. Next, use the release lever to open the opposing ends of the FM extractor and lubricate the blade with the FM extractor lubrication wipe. Next, identify the tapered cutting valleys in the bow tie fastener. Place the blade of the FM extractor in between the face mask bar and the cutting valley of the bow tie fastener perpendicular to the face mask bar. Carefully rotate the blade of the FM extractor so that the cutting surface of the blade rests in the cutting valley of the fastener. Next, secure the anvil of the FM extractor on the face mask bar using the semicircular notch. If it is not possible to get the face mask bar into the semicircular notch, rest the FM extractor's superior notch on the face mask bar. With the anvil secured, begin ratcheting the FM extractor to transect the bow tie fastener. After completing the cut, push the release lever to disengage the ratchet mechanism. If If the FM extractor does not disengage from the helmet or fastener, simply use the anvil as a pivot point and carefully rotate the FM extractor downward to gently remove the blade from the helmet shell or fastener. Repeat the process on the other side of the bow tie fastener, being sure to lubricate the blade between each cut. The result of this process will be that both ends of the bow tie fastener will fall away, leaving a square remnant that the face mask can easily clear during face mask removal. The forehead fasteners on the Revolution football helmet resemble smaller, less bulky versions of more traditional loop strap fasteners. This makes them quite easy to cut using the same FM extractor techniques for cutting through traditional forehead loop strap fasteners in the event that removal using a power screwdriver is unsuccessful. In the event that attempts to remove the fasteners using a power screwdriver are unsuccessful, there are two techniques for cutting the Revolution forehead loop strap fasteners using the FM extractor. Position the FM extractor by resting the anvil and blade firmly on the helmet shell above the face mask bar on opposite sides of the fastener. Begin ratcheting the FM extractor, ensuring the blade and anvil remain firmly against the helmet shell. Transect the loop strap at its midsection and release the face mask. If your initial attempt does not result in a complete transection of the loop strap, do not attempt the same process. Rather, reposition the FM extractor by resting the superior notch of the anvil on the face mask bar. Reach the blade across the fastener and make a second cut that will result in a half-inch piece of the fastener falling away. This gap will provide enough space for the face mask to be removed. You may elect to adopt a two-cut chasm nest technique for cutting through these forehead loop strap fasteners. Securing the anvil to the face mask bar using the superior chasm nest of the anvil on the face mask bar, reach the blade across the fastener, tip the blade forward to allow the anvil to grip the face mask bar, and cut the loop strap above the top of the face mask bar. Leave the anvil in place and rotate the handles of the FM extractor to gently pull the blade away from the helmet shell. With the anvil still secured to the face mask bar, place the blade below the face mask bar and make a second cut. These two cuts will result in a 1/2 inch piece of the fastener falling away. This gap will provide enough space for the face mask to be removed. When securing the FM extractor anvil to the face mask bar using the superior chasm nest, be sure to always tip the blade of the FM extractor forward far enough to allow the forks to grip the face mask bar. This will prevent the FM extractor anvil from slipping off the face mask bar while cutting fasteners. This concludes our discussion on using the FM extractor to cut the Revolution bow tie style face mask fasteners. Should you have any questions, please do not hesitate to call on Sports Medicine Concepts.
Alright, so we just covered on how to use the equipment. Now let's talk about some detailed ways to manage a C-spine and a football player backboarded with the gear on. So, in order for me to teach this, I wanted to know what it felt like to be the football player on the backboard being strapped in. What better way of effectively teaching something than being able to experience it for yourself? This is why whenever we practiced extrication and putting people on backboards, we used our fellow students or firemen or EMTs and put them on the backboard to remove them out of a vehicle. We should all had a turn on the backboard to know what it felt like. So I put the football gear on and told somebody here at the Clayton EMS main station, immobilize me on the backboard, strap me down where there's little movement, and I want you to figure out the best way to maintain my C-spine and prevent my head from moving around a lot. So we used the commercial devices, and I felt like there was just way too much movement with those commercial devices. So I said, let's get old school with this. Let's get some towels and let's roll them together, and let's put them beside my head and see if it holds my spine better. Once we did that, I figured out beyond a shadow of a doubt that the old-fashioned towel rolls work a whole lot better than the commercial devices, because as you can see with that picture at the top of my head, it fills those voids a little bit better. I had very minimal movement once my head was taped down and the towels were placed underneath it versus the commercial devices being on my head and being taped down. This was the absolute best way, in my opinion, to maintain C-spine of a football player, and this is for me being on the ground, strapped up, and being that football player. Now, where we talked about the chin straps, This is a good reason why to leave them on if they're not in the way of removing that face mask. I found that if you left the chin strap in place, you minimize that flexion and extension, that backward and forward movement of the head with that chin strap in place. Now, if the patient doesn't have an airway compromise, it would be okay to leave that chin strap in place. But if there's some type of airway compromise and you've got to get all of that gear off, then go ahead and take it off because you don't want that there messing with your airway. So let's do a few more quick quiz questions. True or false? If any doubt exists, place the patient on a backboard. Do you put them on the backboard? Or do you just say, the heck with it, don't put them on? Well, if there's any doubt in your mind, you would put them on the backboard. It is true. Remember, this is directly from our protocol. Default is to put spinal precautions in place. If any doubt exists, always put spinal precautions in place. Next question. Which signs and symptoms would require the player to be placed on a backboard? A. Unconsciousness. B. Altered level of consciousness. C. Bilateral neurological findings or complaints. D. Midline spinal pain with or without palpation. E. Spinal deformity. Or F. All of the above. Folks, like we've said before, if there's a question that's got all of the above on there, chances are it's going to be all of the above. Next question. True or false? Never remove the face mask of an injured football player. What did we say before? If you're having to put a patient on a backboard, always remove the face mask. So the answer to this question is false. Always remove the face mask of an injured football player. Next question. What schools have certified athletic trainers in Johnston County? A. Clayton High School. B. South Johnston High School. C. Cleveland High School. D. Both A. Clayton and C. Cleveland. Or E. None of the above. The answer is D. Both A and C. True or false? Most football games have minimal staff attending. The answer? True. Remember what we said? Sometimes you're just going to have the sports med instructor and a couple students and the coaches. That's all you're going to have. Not every football game is going to have the certified athletic trainer, the orthopedic surgeon, or the orthopedic surgeon staff there on scene. You're going to have minimal staffing when you're there at the football game. All right. Hope you got all the questions right. I would like to give a special thanks to the Campbell University crew that assisted us in making these videos and taking these pictures. In the video, you saw Jackie Knight, athletic trainer, Craig Oates, Brian Krinsky, Casey Brannon, and Demarion Jones, which was an actual Campbell University football player. A big thank you to those guys for helping us out. And if there's any question about what we went over and you wanted more information in detail, there was a lot of research that was put into the making of this presentation. I've got all this information in my office. All you've got to do is shoot me an email, send me a text, or come on by and see me, and I can let you read all the articles that was printed out that helped build this CME session. And like I said, there was quite a few of them that was published that helped assist along the way. So once again, thank you for attending Johnston County's online CME session. I hope you learned something interesting, and I hope it's something that you can take to the football games that you help cover, whether it's on an ambulance or you're assisting as a first responder there with your fire department. Remember, we're there to assist, we're not there to take over. Let them know that you've had the training, you've had hands-on, you know how to remove this gear, and if there's anything that they would like you to assist with, you know, ask them, what can I help you with? And if it's something you're not comfortable with, not familiar with, please let them know. That way that they can make arrangements to handle that situation.